Welcome to the Deep Dive. This is where we take your source material, strip away the noise, and uncover the essential insights you need to feel truly well-informed. Today, we're plunging into a set of notes focused on a crucial clinical condition, especially if you're looking at medical context, maybe revising for the MSRA. We're talking about Hyperemesis Gravidarum. We've got a detailed medical overview right here, and our mission is basically to break it down, clarify some of the trickier bits, and really highlight what's high yield for you.
That's exactly right. We're aiming to go beyond just, reading the text. We want to help you connect the dots on Hyperemesis Gravidarum, HG as it's often called. So you understand not just the facts, but their clinical relevance, from actually spotting it to managing it effectively.
Okay, let's get into it then. At its core, the notes describe HG as severe pregnancy-related nausea and vomiting. But this is way beyond standard morning sickness, isn't it? What actually makes it severe enough to get this label?
Yeah, the sources are quite clear on that difference. Severe means intractable vomiting. So persistent patients often can't keep anything down at all. And crucially, it leads to significant weight loss. The notes specifically say more than 5% of their pre-pregnancy body weight. Add to that signs of dehydration, electrolyte imbalances, think sodium, potassium levels getting out of whack, and ketosis, where the body starts breaking down fat for energy because it's essentially starving. Those are the big signals indicating a serious condition, often needing hospital admission.
So that 5% weight loss figure, that's a really specific cutoff point then, not just, losing some weight.
Exactly. It's highlighted in the notes as a key diagnostic threshold. It separates HG from the milder nausea and vomiting you often see in pregnancy. It points to a level of metabolic trouble that really needs proper medical attention.
And how common is this severe form? Is it something you see often?
Well, it's not super common, no. The notes say it affects about 1% of pregnancies, and it typically shows up relatively early, usually kicking in between 7 and 20 weeks gestation. That timing is also a useful clue.
Okay. So why? Why does this happen? The notes call it multifactorial, which always sounds like code for we're not entirely sure, or maybe it's complicated.
Yeah, it definitely is complicated. The notes point to a real mix of things. Hormones are a big part, psychological factors can play a role, and there seems to be a genetic element too. But they really zero in on one major potential player: elevated levels of human chorionic gonadotropin, ACG.
The main pregnancy hormone.
That's one. It peaks in early pregnancy, right when HG symptoms tend to be at their worst. The sources strongly suggest this hormonal surge is a likely key trigger for the severity.
So it might be the sheer amount of that hormone just overwhelming the person's system.
That seems to be a core idea coming from the notes, yeah. It's thought to affect the sensitivity of the nausea centers in the brain, and it can also mess with gut motility, how things move through the digestive system.
Okay. Building on that, who's more likely to get this severe form? The notes listed several risk factors.
They did. A strong one is if you've had HG yourself in a previous pregnancy, or if it runs in your family. Multiple pregnancies, like carrying twins or more, definitely increases the risk. Makes sense? Probably higher hormone levels.
Right.
Also, a history of motion sickness or migraines seems to predispose people. Which is interesting, right? Because those also involve a sort of sensitivity to nausea triggers.
Yeah, that is interesting.
Other things mentioned are being younger, and if it's your very first pregnancy, the technical term is nulliparity.
Any less obvious connections the notes point out?
Yes, a few. The sources link it to conditions like hyperthyroidism, also trophoblastic disease that's related to abnormal placental growth, and often involves really high HCG levels.
Okay.
And obesity is mentioned too. And then here's the really surprising one, the counterintuitive finding. The notes explicitly state that smoking is associated with a decreased incidence of hyperemesis.
Hold on, smoking reduces the risk. That seems completely backwards compared to almost everything else in medicine. Any idea why? Do the notes explain that?
They don't really elaborate on the why behind the smoking link, no. But given the emphasis on hormones and gut factors, it makes you wonder, doesn't it? Maybe nicotine affects gut movement or hormone signaling in some way that, just in this specific situation, dampens the nausea. It's definitely a surprising fact that stands out. Makes you stop and think.
It really does. Okay, so moving from the why to the how, the pathophysiology, the notes say it involves hormonal, gastrointestinal, and neurological factors. Can we unpack a bit more how these things interact to cause the HG symptoms based on the sources?
Sure. The notes suggest it's this complex interplay. Like we said, the high HCG seems a major trigger, maybe making the brain's vomiting center more sensitive. The sources also talk about abnormal gastric motility, basically. The stomach and bowels aren't moving things along properly. That definitely contributes to feeling sick and vomiting. So you've got these pregnancy hormones affecting the brain and the gut, kind of creating this perfect storm for severe symptoms.
Got it. So if someone pregnant comes in feeling incredibly sick and vomiting a lot, it's not automatically HG, is it?
Yeah.
What else needs to be on the radar? What are the differential diagnoses mentioned in the notes?
Absolutely vital point. You have to think broader. The notes list several key things to rule out. Obviously, standard morning sickness, the less severe kind, is number one.
Mm.
But you also need to consider things like gastroenteritis, a stomach bug.
Right.
Urinary tract infections, UTIs, can sometimes present with nausea and vomiting in pregnancy, appendicitis too, even liver disease. Getting the diagnosis right is crucial because obviously the treatment for appendicitis is very different from the treatment for HG.
It's total sense. Don't want to miss something else serious. Okay, zooming out again, the bigger picture epidemiology. What do the numbers tell us about HG prevalence and how it varies?
The notes give a range, typically between 0.3% and 2% of pregnancies. They do highlight that the frequency can vary a bit depending on ethnicity, socioeconomic factors, and the mother's age. The sources also repeat some of the risk factors we already touched on: hyperthyroid issues, previous psychiatric illness, a history of molar pregnancy, again that HCG link, pre-existing diabetes, certain gut disorders, and asthma. And they confirm again that the risk seems lower with smoking and also if the mother is over 30.
And there was that other fascinating detail mentioned in the notes about the baby's gender.
Yes. Another really curious point from the sources, they note that HG seems to be more common if the fetus is female. Specifically, the risk goes up with a single female baby, and interestingly also with multiple male babies, or a mix of male and female twins.
Oh.
Yeah, another piece that just points towards these really complex hormonal or maybe genetic interactions that we don't fully understand yet.
Okay, let's bring it back to the clinical side. What does someone with HG actually look like when they present? Key clinical features.
Well, the defining thing, as we keep saying, is that severe, relentless nausea and vomiting, usually starting in early pregnancy. Beyond that, you're looking for signs of dehydration, things like a dry mouth, feeling dizzy, maybe their heart rate is up, blood pressure might be low. If it's quite severe, you might see signs of those electrolyte problems on blood tests, and often you'll find ketones in their urine showing they're in that starvation state.
And the diagnostic criteria, the specific checklist almost. The notes mentioned a triad.
They did. The notes kind of boil it down to this: persistent pregnancy, nausea, and vomiting, plus evidence of dehydration, plus electrolyte imbalance, plus that key threshold, again, losing 5% or more of their pre-pregnancy weight. Those things together in the context of pregnancy sickness really point towards the HG diagnosis, according to these sources. That 5% number is definitely one to remember. It's high yield.
So we suspect HG based on how the patient presents and those criteria. How do we investigate? What tests are crucial, according to the notes?
Right, so the sources list the essential investigations. These help confirm the diagnosis, figure out how severe it is, and crucially rule out those other possibilities, the differentials we talked about. Standard blood tests are key. A full blood count, FBC, that might show hemoconcentration if they're very dehydrated. Urea and electrolytes. UNE is absolutely vital for spotting those sodium and potassium imbalances. Liver function tests, LFTs, they're usually normal in HG, but you check them to rule out liver problems. And thyroid function tests, TFTs. Important because, as we said, hyperthyroidism is a risk factor and can sometimes look similar.
Any other tests mentioned?
Yes, definitely urine analysis, that's vital.
Yeah.
It'll typically show ketones, ketonuria, confirming that starvation state. It might also show a high specific gravity because the urine is concentrated from dehydration. And importantly, it helps screen for a UTI, one of those key differentials.
Yeah.
And then an ultrasound scan early on is really important too. It confirms you've got a viable pregnancy that's actually inside the uterus where it should be. It also helps rule out multiple pregnancies or that trophoblastic disease we mentioned, both of which increase the risk of HG.
The notes also made a specific point about repeating investigations, which sounded quite practical.
Yes, they did. The sources are pretty clear on this. If the initial TFTs and the ultrasound were normal when a woman was first admitted for HG, there's generally no need to repeat them if she gets admitted again for the same thing later on.
Saves time and resources.
Exactly. Avoids unnecessary tests.
Now, when does it actually become necessary to admit someone to hospital for HG? What are the criteria for referral mentioned in the notes?
The notes lay out clear triggers for bringing someone in. If they have ongoing nausea and vomiting and just can't keep down liquids, or even the anti-sickness tablets they've been given, that's one reason. Also, If they continue to have significant ketones in their urine, or they've hit that 5% or more weight loss mark despite trying oral antiemetics at home or in an outpatient setting.
Okay.
Another trigger is if you suspect something else is going on alongside the HG that needs IV treatment, they can't take by mouth, like if you think they might have a UTI needing 5E antibiotics. And the sources add quite sensibly that you should have a lower threshold for admitting women who have other existing health problems, like diabetes, which could be seriously destabilized by the severe vomiting and dehydration of HG.
Right, makes sense. Okay, so once someone is admitted or needs more intensive treatment, how is HG managed? The notes focused on the UK approach.
Yeah, the management strategy described has several goals. Obviously, relieving the symptoms, preventing those serious complications we'll talk about, and supporting both the mother and the baby. Initial steps often involve general advice. Dietary changes, the notes suggest small, frequent meals, often high-carb, low-fat, can be better tolerated. Getting enough rest is important too. And ginger. Ginger may help, is what the notes say. Its effectiveness seems quite variable person to person, so worth trying perhaps, but not a guaranteed fix.
But for the more severe cases, it's really about fluids and medication, right?
Absolutely. If someone is significantly dehydrated, the cornerstone of treatment is replacing fluids and electrolytes intravenously, IV fluids. The notes mention Hartmann's solution as a common choice. Nutritional support might be needed if they really can't eat for a prolonged period. And critically, the sources really emphasize this routine thiamine supplementation, vitamin B1.
Why is that so critical?
It's vital to prevent a devastating neurological condition called Wernicke's encephalopathy, which can happen with severe thiamine deficiency, often triggered by prolonged vomiting and poor intake. It's a medical emergency, so preventing it with routine thiamine is standard practice.
Got it. Non-negotiable.
Pretty much. Also, for anyone admitted and likely to be less mobile, the notes mention considering thromboprophylaxis treatment to prevent blood clots, DVT or PE, because pregnancy itself increases clot risk, and being unwell and dehydrated adds to that.
And then the anti-sickness medications, the antiemetics. The notes listed quite a few kind of in stages or lines of treatment.
They do, yeah. The sources outline a clear, stepwise approach. First-line antiemetics, the ones you typically start with, include things like cyclizine, prochlorperazine, promethazine, and chlorpromazine. The notes even give specific example doses and routes, like cyclizine 50 milligram, which can be given by mouth, or as an injection into the muscle or vein, usually every 8 hours. Similar details are given for the others in that first-line group.
And if those aren't cutting it?
Then you move up to the second-line options. The notes suggest trying these for up to about 5 days. This list includes metoclopramide, domperidone, and ondansetron. Again, they provide specific doses and routes, like metoclopramide 510 milligrams, PO, IV, or IM, every 8 hours. Domperidone, PO or rectally, every 8 hours. And ondansetron, which can be given as tablets, 4 to 8 milligrams every 6 to 8 hours, or as an IV infusion, 8 milligrams over 15 millins every 12 hours.
Okay. And for the really tough, stubborn cases?
For what the notes call intractable severe HG, that's when you consider third-line medications. Corticosteroids are the main player here. A typical approach might be starting with hydrocortisone the maybe 100 milligrams twice a day, then switching to prednisolone tablets, say 40-50 milligrams daily, which is then slowly reduced or tapered over time. PPIs, proton pump inhibitors like omeprazole, maybe IV 20-40 milligrams once daily are also mentioned. These can help if there's significant acid reflux or irritation of the esophagus from all the vomiting.
That additional information section in the notes also seemed to flag some really important points about these meds, especially safety things to keep in mind.
Yes, absolutely critical details in there. They strongly repeat the point about routine thiamine, cannot stress that enough. Preventing Wernicke's is key. They also note that corticosteroids, while effective for severe HG, should ideally be considered after the first trimester if possible, and used with caution, because there's a small associated risk of cleft palate noted in the sources.
Okay.
Similarly, the sources point out that ondansetron used during the first trimester has also been linked to a small increased risk of cleft lip or palate. Now, these are small risks, but it's really important for doctors and patients to be aware of them when weighing up the benefits and risks of treatment, especially early in pregnancy.
Absolutely. And the notes also specifically mention that sometimes admission is needed just for IV fluids, right?
Yeah.
Even if medications are being managed.
Exactly. If someone simply cannot maintain hydration orally, IV fluids alone can be reason enough for admission.
The notes mentioned a scoring system as well.
Yes. The PUQ-E score, that's the Pregnancy Unique Quantification of Emesis score. It's mentioned as a validated tool that helps doctors objectively assess and classify how severe the nausea and vomiting actually is. That can help guide treatment decisions and track progress.
Right. Okay, looking ahead then, what's the general outlook for someone who goes through HG? What's the prognosis like?
Thankfully, with proper and timely management, the prognosis is generally good. For most women, the really severe symptoms tend to ease up as the pregnancy goes on, often improving significantly after around 20 weeks. And full recovery after the baby is born is the norm. However, and this is an important point for counseling patients, the notes do caution that there's a pretty significant chance of HG happening again in future pregnancies.
Okay, good to know. Finally then, let's cover the potential downsides. If HD isn't managed well, or sometimes even despite good management, what are the complications that can arise?
Yeah, the sources list a fair few potential complications affecting both the mother and sometimes indirectly the baby. For the mother, the big ones we've touched on, severe dehydration, those dangerous electrolyte imbalances like hyponatremia, low sodium or hypokalemia, low potassium, significant weight loss, and malnutrition. And don't underestimate the psychological impact. The notes mention significant distress, anxiety, and depression are common. Then there are the rare but very serious maternal complications listed. We've hammered the point about Wernicke's encephalopathy from thiamine deficiency. That's a major neurological emergency.
Yeah.
Others mentioned include Mallory Weiss tears, that's tearing in the esophagus lining from forceful vomiting. Central pontine myelinolysis, another rare neurological issue linked to correcting low sodium levels too quickly. And acute tubular necrosis, which is a type of kidney injury from severe dehydration. Other possibilities listed, some very rare, include acidosis, deficiencies in other B vitamins like B6 or B12, retinal hemorrhages, splenic avulsion, rupture of the spleen, pneumothorax, collapsed lung, and even some potential postpartum complications. The sources also add that some of these rarer complications can unfortunately still occur even later in pregnancy, beyond 20 weeks sometimes.
And what about for the baby? Are there direct risks?
The sources mainly link fetal issues to how severely ill the mother is and for how long. They note a higher incidence of babies being born with low birth weight and also a higher rate of preterm birth. This risk is particularly highlighted in settings where maybe access to prompt and effective treatment is limited.
Wow, okay. That was definitely a comprehensive deep dive, pulling apart all those essential details from the notes on Hyperemesis Gravidarum. We've really gone from identifying the key signs, looking at the possible causes and who's most at risk, walked through the investigations and diagnosis, laid out that step-by-step management approach, and covered the outcomes and those potential, sometimes really serious complications.
Exactly. And really grasping these nuances, that specific 5% weight loss figure, the electrolyte concerns to watch for, the different lines of antiemetics and their safety points, the absolute necessity of thiamine, that's where the really valuable high-yield information lies within this overview, especially if you're revising.
So what's the big takeaway here? I guess it reinforces that HG really is a distinct, severe condition. It needs prompt recognition, structured management. As the sources clearly outline, it's definitely not just bad morning sickness.
For sure. And it does leave you with some intriguing points, doesn't it? Thinking about those links to fetal gender, that really surprising finding about smoking decreasing the risk, and then tying that back to the mechanisms involving hormones like HCG and changes in gut motility, it just highlights how complex this condition is and perhaps how much more there is to learn about exactly why it hit some people so hard. There's clearly this interplay of factors the notes point to, but the exact contribution of each, that still feels like an area ripe for more understanding.
Absolutely. Definitely food for thought. Well, we really hope this deep dive into your sources on Hyperemesis Gravidarum has been helpful for you, making the key information clearer and easier to recall.
And if you are preparing for the MSRA or similar exams, remember that using targeted revision resources that pull out this kind of high-yield information is incredibly useful.
Yeah, definitely check out pastmsra.com and also freemsra.com for more help with your studies. You can find some fantastic materials, including free stuff there too.
Great. Well, thanks for joining us for this deep dive today.
Until next time.